Thanks so much for having me today. I'm really excited to get to talk to kind of a group of folks who kind of get technology. Because for lots of years I've been doing presentations where the first, 3 to 4 slides are, why is technology important? And who are the people it's trying to help? And how does it help our organizations? And when I talk to folks who are well embedded in technology, people who research in technology, I get to kind of skip all of that part. Because I feel like we've all drunk the digital health Kool-Aid, so we know that it's a good idea. And yet, we know it's a good idea, but the rate of adoption in our health systems here in Ontario, across Canada, and internationally are kind of going at a glacial pace. And last year, JMIR had its 20th anniversary, and there were some great articles that came out in that year, and one came from Haddad and Haddad Garcia, which was a pretty grim assessment of where we've come to, what the vision was 20 years ago for how digital technology might transform the way we think about and the way we engage in health, and what's actually happening today. And they say, sadly, the promises of information and communication technologies to transform healthcare services remain unfulfilled. There was a little bit of hope at the end of that paper, but overall you kind of came out of it thinking, oh my goodness, what are we going to do next? And really this is an issue of implementation. And so that's where I'm going to kind of land on today. I'm going to talk about implementation a little bit more deeply rather than the value of, and which suits me fine. I'm an implementation scientist. I've also been accused of being a methodologist. So I'll talk about methodology a little bit as well today. And so the implementation of technology literature has been growing and growing. There's thousands of papers on digital health and hundreds of those specifically talking about implementation. And we've got lots of different ways and frameworks to understand what are the implementation kind of components we need to think about if we're trying to put a technology into practice, into people's hands, and actually make it work. And these kind of domains that you see in front of you are brought together from different types of frameworks, but they're the ones that tend to bubble up to the surface. So we know things about the technology itself are really important. What are its functions? Is it usable? Is it understandable? Is it seamlessly integrated? Things like that. We know the characteristics of the people who are using the technology are important. Are they tech savvy? Do they understand how their systems work together? Do they know how to search for things? Are they just kind of open to engaging in new technologies? We know the inner setting is really important. How are the organizations set up to take on these new technologies? So are they giving resources to people? Are they giving training to people? Are they generally open to change as a culture? The outer setting we also know to be critically important. What are the policies in place that allow us to share our data and share our information? What are the governance structures? And again, what are the funding models that allow us to or to not use things like new virtual care systems? And then finally, the process of implementation is important. How did we present this technology to a new person? How are we engaging in the change management processes to help them adopt that? And for you guys here at Trillium, you're going through this very big process now of adopting a new technology system. And likely many of these components are starting to bubble up in the way that you're thinking about bringing Epic into Trillium Health Partners now. And beyond just understanding what the components of implementation are, there are now some new frameworks that are telling us how those different components can interrelate over time and how we can use those to actually change the way we do things to improve implementation. So a couple of frameworks I tend to really like. One is the value proposition design framework. This came from folks from the Women's College Hospital Institute for Virtual Care. There's a longer title there, which I don't entirely remember, but they're called ViV, and I'm sure you all know who they are. And this was work led by Jay Shaw and his colleagues over there. And this model is a quite simplified, elegant model that suggests to us that we need to think very carefully about value to the people, to the teams, and to the routines and practice over time as we are adopting technology, taking this very system user-centered design approach to doing that. And the suggestion being that if we think about value of technology to all of these components over time, that should help our implementation. Similarly, but a little bit more hectic, is Greenhalgh's and her team's non-adoption, abandonment, scale-up, spread, and sustainability framework, or the NAS framework. They've been doing lots of work of implementing technology in the United Kingdom for many years, and this is similarly focused on value, a lot more components. It's very clearly aligned to the implementation factors I presented a couple of slides back. But still the central focus, like value proposition design, is on value. What is the value to the people, to the organization, and to the system of that technology? And those things should be driving the way we think about adopting technology into our models, our teams, and our systems. But the challenge is, how do we actually uncover what value is? And how do we understand what that value means? And for these two frameworks, they suggest we ask questions, that we ask very specific questions at different times in the implementation process to help us uncover what value is to the different players. So these are just a couple of example questions, and I bring these out because it demonstrates that these questions can be asked at different levels. At the level of the problem, for instance, is there a good agreed upon problem that this technology is solving? At the level of the team, what are the changes in team interactions that we need to think about? And then up to organizational type questions. How does procurement and change materials or change managerial practices kind of engage here? So these questions are really important, and they're foundational, and they do allow us to operationalize some of those implementation factors that the literature suggests are important to us. But what I'm going to talk about today is that while the questions are really important, how we actually listen to the answers is equally important. Because if we listen carefully enough, we don't just uncover what value is, but we can understand what's meaningful to the people and the organizations as they go through their daily practice and as they engage in their technology. And today I'm going to argue that meaningfulness is critically important to how we implement, develop, and evaluate our technologies. And the notion of meaning in technology is not new. In 2010, lots of literature around meaningful use was coming out, and this is really about how we effectively and efficiently use EHRs to their full functional potential. That's not what I'm talking about though today. That's very functionally focused and again has its place, but that's not where I'm going today. Today I want to talk about philosophical meaningfulness and psychological meaningfulness for the people and organizations that are adopting technology. And if we go back to some philosophical understandings here, we can see that the argument is that meaning is related to things like promoting good, our subjective satisfaction in life, achieving our life's aims and goals, or some hybrid of those things. And it is argued that in achieving these aims, we perceive that we're leading meaningful lives. And this is helpful for us in healthcare because these are the same kinds of drivers that bring people to do clinical work often, that they find meaning and purpose in the work that they do, and that brings them here. But still, you might be asking, why is this important when we're implementing digital technology? Maybe really important as you're thinking about hiring clinicians. Are they seeing meaning and purpose? Why does this matter when we're talking about technologies that support processes? Well, a couple of reasons. One is that meaning drives our behavior. So self-determination theory shows us that what is important to us, how we set our life goals, will really direct how we behave in our day-to-day lives and how we interact with people. And in the organizational behavior literature, we know psychological meaningfulness associated with work will incent engagement. And behavior is really important when you put a new technology in front of somebody and say, hey, I want you to use this now. And I want you to change the way you're doing things. And what these authors, for instance, Kahn's work in psychological meaningfulness, have shown us that if people find meaning in it, if they're personally attached to it, they're more likely to change the way that they work and more likely to feel connected to their organizations. And you can even take that a whole step higher, as Chalosky and Krishna show us, that it actually can relate to our achievement of self-actualization and self-transcendence, as they argue in this particular paper that if we see perceived meaningfulness in our work, if we have perceived meaningfulness at work, that we actually enter this process of flow where we derive meaning from the work that we're doing and not from the tasks that we accomplish. And in doing that, we can create some emotional commitment to our organizational environment. And if we think about the challenges of implementing technology, which often come into that place of engagement and belief and behavior, suddenly meaning starts becoming really important. On the other end of things, technology itself can also shape meaning. And I think we miss this point a lot in health services research, although our sociological friends have been digging at this for a little while. That technology isn't just a piece of a tool that's in front of us that's allowing us to do functional work, and then we put it away and we're done with it and it doesn't shape us. Sociologists have been finding that it actually does, in fact, shape the way we think about ourselves, shapes how we create meaning in our lives. And in healthcare, as Deborah Lupton shows us, that they are actually active participants that shape our bodies, ourselves, as part of our heterogeneous networks and create some new practices and knowledge and way that we work. So meaning not only shapes our behavior, but the technology itself is shaping the way we think about ourselves and the meaningfulness in our lives. And we can link some of these things back to some of those implementation papers around technology themselves. Things that we've seen that individual characteristics like beliefs will change whether we can successfully implement technology or not. From a process standpoint, we've seen that if people are engaged in the process, they start having a sense of ownership over it, and it starts to speak to who they are. We see impact on implementation as well. So that meaningfulness is starting to come out, although not explicitly, we can see it kind of in an underlying theme in some of this work. So I'm kind of presenting a really simple framework here to help us understand this, that I'm going to talk about in 3 different buckets in a moment. That meaningfulness is important because it's driving our behavior. And behavior is important because it's going to help us implement our technology, and thinking about the technology in turn is shaping our meaningfulness, and all of these things interrelate, and we need to attend to them if we're going to support strong, meaningful implementation over time. Now, these things do, of course, occur within our internal and external environments. I'm going to focus a little bit more on the center, though, today. Now, simple as it is, there still remains kind of 2 problems here that we need to address. The first is that we struggle to pick up on meaningfulness because people have different abilities and willingness to express what's meaningful to them. There's actually an interesting whole branch of cognitive psychology where the place in our brain where emotion, belief, meaning sits is completely severed from the place in our brain that does language, which is why we struggle to accurately describe why we care about something, why we love something, why we get up at 5 in the morning every day to train for the Boston Marathon, as Dr. Kaliski is currently doing. But when you try to describe that to people, you kind of land on these like clumsy metaphors and getting at it, but you're not really quite describing what you're feeling. So it becomes really difficult for us to understand what's valuable and meaningful because we're just bad at saying what's valuable and meaningful to us, because apparently that's how our brains are structured. Similarly challenging is that many of our interventions have a hard time connecting meaningfulness to our implementation efforts. And it becomes especially hard when we have complex interventions with lots of people, lots of organizations, complex technologies that all have different meanings to them, different values that change over time. So not only do we have to unpack all of the meaning for all of those people and do it well, but we need to think about that as that is changing and interacting with itself over time. Now, thankfully, we actually have a whole methodology to help us unpack meaning in qualitative research. So I'm going to be talking a lot about how qualitative work can help us unpack meaning over the life course of our technologies. And when we get it right, we can develop our technologies with a better understanding of what the needs of our users are within their personal and social environments. We can evaluate more effectively because we can identify the underlying mechanisms that actually drive our interventions. And we can perhaps implement more successfully because we're aligning the technology to the aims of the people and the programs in which they're intended to support. So I'm going to go through each of those three things and use kind of some examples from the work that myself and my team have been doing in technology and more broadly in integrated care to unpack why meaning is becoming important in those three different areas. So starting with user-centered co-design. I'm going to be talking about a project called the Electronic Patient Reported Outcome Tool. It's a mobile device we've been developing and testing for the last 7 years and couch the development of this within a co-design method. Now, co-design is interesting because in some folks in the technology space, when I present, we're going to go and develop or co-design something together. I had an experience with a technology partner 2 or so years ago. We were designing a new platform for physicians to help educate them and also for nurse practitioners around dementia care practices. And I suggested, okay, well, we need to co-design this to do it well. And the technology partner on the group was like, well, if we had co-designed, transportation services in the 19th century, we wouldn't have had cars. We would just have had faster horses and buggies, which is a very old user-centered design adage. And I noticed, maybe too late in the game, that the public domain image I've used of the second one has horses on skateboards. So I'm not sure. So right? So my apologies. That's an interesting co-designed horse and carriage, but there you have it. But that adage. It rests on two kind of faulty assumptions about what co-design is. The first being that only designers are creative, that they're the only creative people who create creative thoughts. And second, that co-design is building exactly what people tell you to build. And both of that misses the point of co-design entirely. And to the first point, Sanders and Strapper's kind of quite foundational writing on co-design suggests to us that actually everybody in the room can be creative in different ways and actually open windows to understanding what's in front of us in a more diverse way than if you just have one designer with one perspective within a room. And they suggest to us that you need to move a little bit more over to the left, thinking about your users as partners in the development and design of our technologies and our models in order to benefit from that kind of creative thinking. Now, the second assumption is around a misunderstanding about what having someone tell you they want needs to be literally designed into it. Because what we've found is that while Sanders and Strapper suggest to us user as partner is really critical, we've actually found that it needs to oscillate between user as partner and user as subject. And sometimes, yes, we are kind of designing alongside each other, but sometimes we need to take a step back and hear what it is our users are saying to us and use interpretive and analytic lenses to unpack what is meaningful to them. Because in them telling us what a particular feature is they think that they want or that they say that they want within a technology might make sense to them at the time, there might actually be something underneath that requirement that's more aligned with what's meaningful to them. So they might say, well, why can't it just ping my provider anytime I want to talk to them? And they might not actually want to ping a provider at 2 or 3 in the morning, but what they're saying to us is they want to feel connected to the person who's caring for them. And they want to feel that connection whether they're in the clinic or not. And that doesn't mean necessarily building a ping as they asked us to do, but that does mean that we need to think about how our technologies create connection and communication over time. So we took that idea and built a very simple framework for 7 years of intensive work to design and develop and evaluate the ePro tool. And I'm going to talk at a very high level about some of the key learnings from each of these pieces through the next little bit, but I'll show you where the links to the publications are if you want to take some deeper dives. So in terms of the needs assessment, this was where we really started with users as subjects, really high-level focus groups with patients with complex care needs, so multimorbidity, social complexity, in and out of the primary care clinic a lot. We do this work in primary care, and asked very generally, what's important to you in your care? Our focus group guide had like 2 questions on it, and that was really the first one, and that first one really drove about an hour of conversation. Then often, in some cases, their caregivers were in the room with us, and we took a lot of that to distill down in using interpretive, descriptive, and analytic techniques from qualitative methodology to uncover what was meaningful to people in describing these things. We did a little bit of user as partner toward the end. We presented them with some technologies and thought about that in relation to what they said was meaningful to them at the beginning of the conversation. But mostly we focused on what was important, and where we landed was on this framework. And really for them, what was important being complex, living in the community, trying to live the life they wanted to live, they wanted to see some better information sharing. They wanted to talk more to their primary care provider. They wanted to have more information sharing with their other providers because they had lots, they're complex patients. But they also really wanted to see better information sharing between all of the players in their game. And I think, when we first did this work in 2014, this felt novel, and now we're moving towards Ontario Health Teams and integrated care, and we all know that this is critical. Information sharing across the system is important. But so we took this and we started saying, okay, now we're going to design a technology that helps us do that. And we focused on primary care because we were doing primary care research at the time. We presented this in the next phase to providers, giving them care within the primary care, an interprofessional and integrated primary care team, and said, does this resonate? What's important to you? And let's design something that works as well. So then we designed a prototype that had some validated outcome measures that connected to what the types of symptoms patients said were important, because the providers told us they needed to understand the symptomology of patients. So we thought, okay, well, that's the information we need to share. Let's go with that. And we presented it to them through working groups. So they worked together, they looked at the technology, actually used it, and we had completely missed the mark entirely. And we had to do a massive change to our development, and it's because we didn't pay enough attention to what was meaningful. We were being way too literal about what they were saying to us. Because the patient, what they were really saying was they wanted to communicate with their providers and be partners in their care. It wasn't just about sharing symptoms, they wanted to be partners, and the providers wanted to capture patient information that helped them make decision making. We ended up landing on standard symptom measurement because we thought that would help both those people, but that wasn't really aligning what was important to them, right? What they really wanted was that partnership and decision making. So we ended up changing things a little bit and being more aligned to what we thought was goals. So we still hung out in the symptom place, but we allowed people to link the standard outcome measurements for symptoms that they said were really important to them to types of goals that they might set for themselves. Things like, this is about your social activity, this is about your physical health, things that should be important to them. And we ran it as a usability pilot for 4 weeks with 11 patients and one family health team. We had a lot of use because we were getting closer to what was important to them. But it was still a static tool. It was picking up on things that were important in their daily lives in a very focused, static, validated outcome measurement type of way. So you're using things like the PROMIS set of tools for health, quality of life and for general health, and fine, but doing that once a week or every day wasn't really getting at what they meant by social inclusion, by what's important to them in their mobility, what's important to them in their physical health over time. And so we had another pretty significant pivot towards a technology that would actually allow people to set goals and measurements as they needed. They can set any kind of goal. It doesn't have to be aligned to a validated measurements tool, and then they could set any ways that they would want to check in on that tool. And then suddenly that we're actually getting at what's meaningful to patients to be partners in the way that they get care with their provider. And to the provider, they're actually getting data that makes sense to the patient, can actually help them make clinical decisions because they know what's important to them in their daily lives and where things are working or not working along the lines of their goals. And suddenly we can actually align meaningfulness, and it makes a lot more sense to everyone in the room. But it took multiple iterations and a lot of testing for us to get to that point. And it took us taking a big step back on our assumptions on what we thought was important to people. Because we thought outcome measurement was important, and it really wasn't. It was about goal alignment, and it was about prioritizing and the way people just live their lives, and how primary care is trying to help people just live their lives, and how can we align information that way. So that's how we developed for meaningfulness. And we continue to do that, we continue to learn. But we also wanted to bring in this lens in the way we were evaluating the technology. So I'm going to talk about the next phase of testing where we did our pre-trial. So here we are at the 4th exploratory phase trial. We did this with 2 family health teams, small number of patients, 16 and 8 different providers. at a high level, patients were meeting their goals. They showed general improvement in their self-management, particularly qualitatively. They were reporting to us they were feeling better. Some people had incredible things like they pulled themselves off of wait lists for hip replacements because suddenly they knew it wasn't their hips bothering them, but it was something else entirely. So they just changed different aspects of their life, and suddenly they're not waiting for 2 new hips and going through all of that process. We had providers who were using the technology, changing the way they were giving care. Really fantastic things we were seeing qualitatively. And we wanted to unpack what's the mechanism of change really happening. And when we took a step back on all of the variables involved, this is all the variables involved in this particular type of complex intervention. So you have to ask yourself, what is it within here that's actually leading us to those outcomes? And some of these are quantitatively collected, but some of them can't be quantitatively collected very effectively, right? They need to be unpacked from a qualitative lens. So we took another step back and wanted to do a deep dive into our qualitative work. And using, once again, Greenhalgh and her team's approach to thinking about technology evaluation using ethnographic and narrative approaches. This was kind of one of the foundational pieces in 2011 from her and her team, but then there have been other examples of people using similar methodologies to understand and unpack our technology. So this is a very simple slide of a ton of work of doing narrative analysis of qualitative work. But basically the lens is we looked at the interviews and we looked at any of our observation notes and any of our memo notes, and we created we restoried and created the stories that patients were telling us about how they use the technology, and then we did the same thing with providers and looked for similar themes within their stories. And the big themes for patients was that it was part of reminding them and monitoring and helping them monitor their progress toward what was important to them. It demonstrated that the role of the provider was a key player within that story for them, and then these expressions varied in terms of how they felt about technology going into it and how they felt about technology over the course of 4 months. In provider stories, what was really important was the felt disconnect between the real world and the research environment we were placing them in. As we're learning about goal-oriented care increasingly through some other work that I'm doing, goal-oriented care is a process, it's not an end, right? We're not really just trying to attain a goal, we're trying to change the way that people interact and create relationships with each other. And because of the iterative and fluid nature of that particular model of care, a tight research environment that is controlled and putting people into buckets and only recruiting at a particular time doesn't actually fit with that particular way that we do care. And for providers, meaningfulness was really important to themselves, to their patients, and whether they were going to engage with the technology or not, and when they engaged with the technology. So when we took our narrative analysis, we overlaid that onto our model and suddenly start seeing clear paths on what is likely leading to the outcomes that we were seeing. Because now not as many of the factors in the context were critical, but things like, as I was saying, the goal-oriented care process were really important. The workflows were really important as well, but really critical was the meaningfulness to the patients and to their providers and how those interacted through the process forward, right? Because what was meaningful to them here influenced what they did through the process and is likely one of the big contributing factors to the outcomes we were seeing. And I think really importantly, that we're learning here, and perhaps as important as you guys are thinking about or going through the process of a very large implementation yourselves, is that meaningfulness was overriding workload concerns. We get so worked up in user-centered design around how can we tightly fit to the user flow? How can we make this seamless? How can we make it feel like they're not doing anything new at all, it's just business as usual? But what we were finding that if it was meaningful, they were willing to change. And one provider told us that this is definitely adding work for us, but because it's taking up time in our appointments, but if that's beneficial to the patients, I'm willing to do that. And we saw people very willing to do that, to change the process of the way their teams functioned, because they saw it as important to their patients, which was important to them at the end of the day. And that's quite powerful if we think about the challenges of implementation. And from a patient perspective, this is actually data from our more recent trial, which just wrapped up in the last few months, of a 12-month study. And this is an example of one of our super users. This is a person who used the technology almost every day for a full year. Actually, this person used it for 13 months. after she was done with the trial, she still actually, we took her phone back and she still went online and updated her data. And we interviewed multiple times and did multiple observations of patients for this 12-month trial. So looking at their narrative and the story, we could see for this particular patient, she had a very clear story. And for her, the tool made sense because she would describe it as who she was in her identity, who it was in the way she engaged in her life. She said things like, it's just, goal setting is just what I do. This is my life. I'm a goal setter. And it's just the way I think about who I am and how I engage in my health. And so it makes sense why she would be using this all the time, because she felt herself within this technology and engaged more with her healthcare, and she felt that the provider was understanding her more and had a very powerful change for this particular person. So how does this all relate to implementation? I think I've been alluding to it a little bit, that we're changing behaviors or changing the way people think about themselves. But I want to take a bit of a detour from technology and talk about implementation of integrated care and how meaningfulness is really important, not just at that granular individual level, but how this makes an important impact for our teams and our organizations. So this is a study that I did with colleagues Jennifer Im, who's one of our trainees and students, and Dr. Jenna Evans, who is a professor at DeGroote at McMaster. And this study was looking at goal-oriented care within an integrated model in Vermont. And we wanted to go in as looking at the implementation of goal-oriented care from a high level. We conducted 18 interviews with providers and managers in 2017, and we also had some observations and document data to understand this. And this is part of a comparative case study. We're looking at Vermont and Ottawa, and some colleagues in Belgium who are doing similar work. But for us with the Vermont data, what we noticed was that the way they were doing goal-oriented care was across multiple different organizations. They had an individual from community sector, from mental health, from housing, from primary care, from hospitals, all coming together bi-weekly, engaging in interprofessional care that was goal-oriented for their patients. They were heterophilous in nature, so totally different professions, different organizations, but homophilous in challenge. They had the same challenge in front of them, which was a complex patient that they were struggling to care for. So we kept asking, how could you possibly get all of these people with totally different aims, totally different organizational visions and missions, all on the same page? And we dove deeply into the data with that lens. And what was helpful for us was taking a shared mental model approach to this. And shared mental models suggest to us that team members within models will have shared and organized understandings or mental representations of knowledge about the elements of what it is they do. So they just have a clear understanding about the tasks in front of them, and they believe the same things about those tasks as they're trying to engage with it. And so we went through the data and we developed what the components of the shared mental model were for these providers and managers working in this environment. And we saw very tight alignment from very different people over an 18-month period of working together, where despite coming from different places, they had overlapping knowledge and beliefs about exactly what goal-oriented care was and how they were doing it, and they knew and they had overlapping ideas of what the tasks were that they needed to accomplish and how they were going to actually work together. And that's very helpful for us from an integrated care perspective, because they're coming from different professional backgrounds and have different thoughts on how we're supposed to care for patients. The alignment piece really came in the goals, and it was pretty incredible to see all of these 18 different people use almost the exact same words to describe goal-oriented care. Because even when our teams are working in the same models, they will have different ideas, but these folks were really coalescing, and that made a huge difference to their ability to implement. They were overcoming all kinds of challenges because they understood the problem the same way. They had shared values and meanings of what goal-oriented care was. It was meaningful to them deeply and personally, and it was meaningful to the organizations. They were able to align that meaning to what the organization was trying to accomplish. It enabled their work across organizational and disciplinary boundaries, and it supported strong relationship building, which is important to doing interprofessional teamwork. So they were a nice coalesced group. We asked them about technology, and they said, well, we tried to put something in, but it didn't really fit with what we were doing. It didn't really align with their interprofessional beliefs. It didn't align with goal-oriented care, and it nearly eroded 18 months of work building the relationship for that team. In fact, they had to just stop talking about technology because it was making people fight. And the practice facilitator that had brought everybody together could see all of the work they had done together start crumbling away, because the technology that they tried to put in there didn't align to the coalesced sense of meaning that they had been creating together over that 18-month period working together. So it's from there that we start seeing that technology is starting to be really critical to be aligned to that meaningfulness. And there's two kind of big reasons that we think that this is important at an organizational level as well as from a team level. That, the literature on implementation of integrated care in other spaces demonstrates to us that, strong vision is really important as we are trying to implement and drive a new model, right? That we have vision and leadership and aligned vision across different partners is really important. So that's the first reason I started connecting these two different pieces of work together, from technology to the implementation work. And the second thing that started kind of tweaking my interest here was actually came from pop organizational literature. Anybody familiar with Simon Sinek's Start With Why? Yes, some people. That's good. I actually forgot to put the citation in here, but ask me and I can share that with you. And essentially, it's a fairly simplistic idea that we are, driven, that why we do things is a much more powerful driver of behavior than simply understanding why. And I think, we've been talking about that from meaningfulness driving behavior. Philosophy shows us this, and different cognitive psychology shows us this as well. The interesting thing, though, in this particular argument that Simon Sinek makes is that he connects that why to how it is we do things and what it is we actually do. And that is the premise within that book that I think is the most powerful, that it's connecting all of the pieces that will actually drive our ability to do something effectively, not just as an individual, but as a team. And we can take that and think about how digital health is potentially achieving our models of why, and whether that is driving our ability to implement or not. So if we think that why is our core aim of the model of care, how is the guiding principles of our organizations and the way we want to be doing things as a hospital or a primary care team or what have you, and what are the activities of that model of care that allow us to align all those things. And often technology sits there, right? We often focus on technologies helping us do the activities of our day-to-day. It has functions, it has processes in place, it's going to build efficiency and effectiveness. That's all very important. And however, where we start falling apart is that it might not actually help us in how we want to actually do things. It could even align to our why, but I'm going to demonstrate how losing how it links to our values and principles can actually erode the entire process. So here's the example I'm going to give you. We have a model that's an integrated community-based primary healthcare model. It's aiming to meet the needs of complex patients living in the community. So this is a general conglomerate example I'm giving you from different types of models that we've looked at from my own work, but also from work in the broader sense. The values of this particular team is they want to be interprofessional, collaborative, teamwork, and they do that through teamwork, and they want to do holistic person-centered care. That's what their driving model. So very similar to like the Vermont example. They have a new challenge in front of them. They have lots of patients who are struggling to manage their diabetes. So they go out and they find a well-evaluated, well-developed, came from the University of Toronto diabetes management app, and it integrates in their EMR. And it looks like a slam dunk. So because it's doing a great job helping patients manage their diabetes, it's been evaluated and tested that way, and it connects to the EMR. So terrific. This should be an absolute win. However, it's also a single disease focused technology, and not all the providers in their team can actually see the EMR. So for patients who, yes, they need to manage their diabetes, but they also have different issues, perhaps some social isolation and other things that are cropping up. If you start handing them all tools that are just focusing on that one thing, suddenly you're not really doing holistic person-centered care. And if not everybody can actually see the data in the EMR, suddenly you're not doing good collaborative interprofessional teamwork, so we've lost it there. And then that actually trickles up to, well, we're not really meeting patient needs, and we're certainly not meeting our team needs. And this connection back to meaningfulness, I think, is important when we think about teams as well. In a conversation with a colleague on this, I was talking about this meaningful innovation piece. We are kind of coming at that it's not just important that it's meaningful to people for their use, but if things become not meaningful, it can actually lead to burnout, right? Like in the example of what was happening in Vermont, it was eroding their joy in that work because it wasn't aligned to what was meaningful to them. Given how much provider burnout we have, lots of research on EMR burnout and causing challenges, meaningfulness becomes even more important, and the avoiding unmeaningful behavior becomes even more important. And we're also seeing that alignment is improving our ability to actually scale and spread ePro as well. So in our trial, our recent trial that has wrapped up, we connected the technology to 6 different teams, and we recruited based on people who said that, yep, we do interprofessional practice, we're person-centered, we do goal-oriented care, we're ready to do this, let's go and recruit people. And what we actually found were that some of the teams weren't exactly what they said they were. Some of them were actually functioned kind of more like a primary single practice provider. So they had people around them, but they weren't working together. Some people did work really well together, but they weren't as person-centered. And then some of them were super person-centered and super connected as a team. And what we were seeing was that those teams who had that person-centered approach that worked already together as a team were much more able to implement and adopt ePro because it aligned really well with what they were doing and was meaningful to them, not just as a team member, but from an organizational standpoint. And we saw people actually change and modify their processes to actually make this work because it was aligned so much more to what they wanted to do as an organization. So I'm going to give 3 general ideas on how we can uncover value. I asked that question right at the beginning. So what we've been doing is we're drawing on qualitative work, and we do it a lot. That's more my space. I teach in qualitative methods. I get to partner with very brilliant trialists who do a lot of the heavy quantitative lifting, and then we dive deep into the qualitative work to see what is meaningful to people over time. We need to recognize, and we continue to do that here, and I would encourage others in the space to recognize that there's disparate and possibly conflicting values when we are putting together a new technology into practice. That even if you're all working on the same team, your senses of meaning, your perceptions of meaning may be different, and we need to be open and clear and have conversations about what that is, especially when we're putting a new technology or a new process in front of somebody. And finally, thinking about how we can be an adaptable environment so you can kind of iterate continuously. Because what we're seeing is that you can talk about someone's meaningfulness and their perceived meaningfulness once, it's going to be different later. Because their environment changes, their organization changes, they're interacting with a technology which might be changing the way they're thinking about things. So we need to constantly be having this conversation and allow ourselves the flexibility to be able to adapt and change. And I look forward to having this conversation with you guys. Thank you for listening.
Thank you.